welcome back. In previous lessons in this particular course, what we've done is we've really tried to talk about kind of what's ideal and how do we idealize a patient's bite and the different refinements in equilibration. But the reality is that there are patients that you're not going to get an ideal occlusion, what I like to call patients who have compromised occlusions. And so what I want to do is in this lesson start identifying what do those patients look like and sort of what is it that we want to try and accomplish with them, but it's not going to end up looking as ideal as what we have in some of the other patients. So when we think about occlusal compromises, one example might be a patient with 100% overbite because of excess overjet, who in fact is unwilling to do orthodontics, unwilling to consider orthognathic surgery, but in this case she wants her anterior teeth restored. So what does that deep overbite do to how we restore her teeth? So that's what I mean when I talk about patients who developing an occlusion in a compromised situation. So with a deep overbite patient, there's a few things to think about. One of the biggest risks that we think about typically with deep overbite patients is a restricted pathway of motion. And that restricted pathway of motion could be that they're feeling locked in. Typically, if they do have that restricted pathway, it shows up as pathway wear on the lingual of maxillary anterior teeth, facial of mandibular anterior teeth. It might show up as fremitus of the anterior teeth, could be mobility or migration of the anterior teeth. In some patients, it will even show up as muscle or joint symptoms. The challenge of deep overbite patients is oftentimes without orthodontics, they're very difficult to manage. So in the lessons following this one, we're going to look at some of these kinds of patients, but truly if a patient could even accept some orthodontics, often some of these types of patients could be improved. Another example of a compromised occlusion, no overbite, patient who is end-to-end. And typically when you have a patient who is end-to-end, it's because they lack overjet. Patients with deep overbite typically have excess overjet. That's how you end up with the deep overbite. So when we see these patients who are end-to-end, they're actually very similar in some ways to patients that have anterior open bites. In either case, they typically don't have what we would think of as traditional anterior guidance. Normally, what we think of is the overbite provides the anterior guidance that mechanically separates, discludes, if you will, the posterior teeth. When you have an end-to-end occlusion or when you have an anterior open bite, you typically don't have any overbite, and therefore you don't have what we'd think of as traditional anterior guidance. So when we think about these patients, these end-to-end cases or anterior open bites, really the greatest risk to them typically is to the posterior teeth. Because of the fact that there is no disclusion, there's no separation of the posterior teeth when the mandible moves, you risk doing things to back teeth, such as fracturing them, making them mobile, etc. So when we see these kinds of cases, anterior open bite case, end-to-end occlusion case, a few typical things that you try and do kind of routinely as a compromise, you at least try and get as many teeth contacting in MIP as possible. And then the other thing you usually do in these compromised cases is, if it's an anterior open bite case, you use the most anterior tooth you can for your guidance. In an anterior open bite case, that would typically be a first premolar would be an example. Now, a couple other things about these types of compromises. If the patient shows up with an anterior open bite already, and you really know that you're not going to be able to close it without, in fact, jaw surgery and orthodontics, there's very little risk of leaving the open bite, assuming that you can get even contacts on all the other teeth and you can use the premolars for guidance. In other words, there's very little risk those anterior teeth are going to suddenly start erupting. If the patient already showed up and they have an open bite, the fact they have the open bite tells you something is keeping the teeth from erupting now. The one thing you really do want to be careful of is if you have a patient who doesn't have an open bite, and you, for example, have a big shift from a seated condylar position into their intercuspal position, and when you choose to equilibrate them, you actually now create an anterior open bite. That's a very unstable case because now those teeth the anterior teeth used to be in occlusal contact. If you've now taken them out of occlusal contact, the risk for them erupting is actually quite high. If we go beyond end-to-end, we go into a full class 3 relationship, again, we now have another occlusal compromise. And when we think about patients with class 3 occlusions, oftentimes what bothers the patient is the appearance. It's very common if you have a class 3 occlusal relationship in the anterior to have a reverse smile line in the anterior, under-erupted maxillary incisors. Sometimes those patients actually function just fine, it just doesn't look good. Now, when we think about treating a class 3 patient, usually orthodontics and jaw surgery is always going to be the number one choice. If the patient refuses to do the orthodontics and jaw surgery, what you have to be very careful of is if you try and treat them by opening their bite and jumping the class 3 relationship, oftentimes what happens is you don't get enough overjet and you lock the anterior teeth in. And now you end up with problems similar to a locked-in deep overbite where the anterior teeth can end up mobile, fractured, migration, etc. So if you are going to try and treat a class 3 into a compromised occlusion, I would tell you typically leaving them relatively end-to-end is the safest compromise for class 3s. I, as you will see in subsequent lessons, have had some very bad experiences when I tried to jump class 3s and was unable to get adequate overjet. So sort of just to get your mind rolling on what we're trying to accomplish then, what we really want to do for most patients, regardless of the occlusion they have, class 2, class 3, even class 1, is when the patient bites, we want to have all the teeth touching at the same time that we can. If we can't get that, we can't get that. But ideally, as many teeth as you can get touching in the intercuspal position, you get. In a class 1 patient, it's easy to have a nice 2, 3, 4 millimeters of overbite, typically provides very nice posterior disclusion. If you can't get that, if you can't get that nice anterior guidance because of the occlusal relationship of your patient, then the compromise typically is to use the most anterior tooth that you can get, but not lock the patient in tightly. So if you didn't have anterior contact, you would get everything touching premolar back and use the first premolars for your guidance. Now, the reality is what makes class 2 and class 3 patients hard is they have an overjet problem. The class 3 patients don't have any overjet, that's why they end up class 3. The class 2 patients have excess overjet, that's typically why they end up with the deep overbite. If we just look at it, it's easy to see when we have a class 1 molar relationship, what we end up with typically is the overjet. If you have all of your teeth and they're normally sized teeth, the resulting overjet allows you to have this very nice relationship in the anterior where you have enough overjet to get you roughly 2 to 3, 2 to 4 millimeters of overbite, which then protects the posterior teeth. So when we think about it, yes, class 1 is nice. We don't always have to have class 1 molar relationships to be successful for sure, but we do have to realize that if we don't have the class 1 relationship, if we do have a class 2 or a class 3, we still want to try and come up with these same parameters of the occlusion. Even contact on as many teeth possible, try and get the most anterior teeth contacting to provide your guidance in protrusive or left or right lateral. And this would just be a visual picture of a reconstruction in a left lateral position, and we see when we have anterior guidance, there is no posterior contact. It's possible in most patients. We get some reduced muscle activity, and then the other thing we get is it protects the posterior teeth because the posterior teeth aren't running into each other. The one thing we always have to be cautious about when we think of anterior guidance, you do have to be careful that you provide nice broad contacts and that your occlusion is not too deep, because if you do miss the anterior guidance, especially canine guidance going left or right, and you have only the tip of the canines contacting as that patient goes across the tip of the cuspids, you can end up with things like this. So anterior guidance is definitely our goal. Even contact on all the teeth at the same time is our goal, but the anterior guidance we build, we don't want it to restrict or lock in the patient. In subsequent lessons, what we're going to do is we're going to look at examples of each of these types of patients, and we'll walk through how they were treated even though they did have the skeletal compromises. Look forward to seeing you then.